and thank you for inviting me, although I think I was third choice, so I'm not sure that's particularly brilliant. Anyway, before I get into Bluteq, I did think I'd cover off a few things about medicines in the round and medicines optimization, as we might like to call it. So we spend a lot of money on medicines. I think we're up to something like 12–13 billion pounds. And we know that actually a lot of medicines aren't taken properly. We think about 50% of medicines aren't taken properly by patients for various reasons, particularly those with long-term conditions. And we know that something like 5–8% of patients come into hospital as an acute admission because of a medicine which could be avoided. So all of us have to take that on board, that when we are prescribing medicines, we need to be prescribing them appropriately, and we need to give our patients the right sort of information so they can use them correctly and take them when they need to. And this is a graph of our spend on medicines. The top line is the total spend, and the bottom line is primary care. And when I came into pharmacy, actually those two lines would have been way apart. So the middle line is secondary care. Spend in secondary care is going to be the biggest spend in the NHS quite soon. So that's actually 2017 when they crossed. So we're probably already spending more money in secondary care than we are in primary care. But actually 80% of medicines are prescribed in primary care. So you can see why we're so anxious that we use our medicines wisely, and particularly in secondary care where the medicines are very high cost in general terms, even more so. Oh, and incidentally, because I recognise the 249 figure because it came from me, we're actually spending £300 million now on MS drugs, and only 1 million of that so far, when this was back at the end of 2018, was cladribine, which will take off, I assume, at some point. So £300 million on MS drugs at the moment. Right, so how do we get maximum value from medicines? Well, first of all, we need to make sure that patients get access to the medicines that they need for their disease. We need to improve the quality of prescribing and medicines use. And we, as the NHS, and particularly NHS England, have a lot of buying power as one commissioner. We can actually go out to companies and say, look, we're not prepared to pay this price for your medicine. And we tender for medicines. Obviously, NICE has a part to play in this because medicines have to hit a particular threshold to get through NICE and have a nice positive opinion. So we can do a lot around that. So the list prices that obviously you see published isn't necessarily what we pay for these medicines. And we need to work with clinicians to get this commissioning for value. So we talked about biosimilars a few minutes ago. But we need to talk to colleagues and patients about where to look, what can we change, and how can we change it. And we're working closely with GIRFT, and I know there was a talk yesterday about GIRFT, about, you know, sort of variation in uptake and maybe trying to understand that variation. And so we have a policy framework. This is the thing called PPRS that some people might have heard of. We're negotiating PPRS at the moment for the new phase, which is basically an agreement with the companies about how much we spend on medicines in totality in the NHS. We can have the commercial arrangements that I've already spoken about, so the things like PAS agreements, so patient access schemes, or we have our own agreements around what we spend on medicines, optimizing medicines and developing the infrastructure to ensure that we're using those medicines as best as we can. So there's things like outsourced pharmacies, there's home care. A lot of MS drugs are delivered through home care routes, and that helps patients because they don't have to come into the hospital for their treatment. And we have commissioning policies. So we've talked about the algorithm, and I'm actually very proud of the algorithm. It's the first algorithm that NHS England has produced on medicines. We've been trying to do cancer algorithms since 2013, still haven't done it. And we've been working on this for 2.5 years. And it's been fraught. And you saw the list of people on the list of people involved, and thank you very much for that. And we did to and fro. But the algorithm is actually about what we commission. These are the things that we already commission, either via NICE guidance, or in actual fact, NHS England, since 2013, have actually implemented certain things that NICE didn't cover, like being able to use fingolimod after glatiramer acetate, because that wasn't part of the guidance, because it wasn't in the license at the time, like fingolimod being used after natalizumab for PML. So there are things that we can do, and I would implore anyone out there who wants to use medicines outside of current policy, mostly NICE guidance, if you want to do that, put in a policy proposition to NHS England, and we will consider it if the evidence is there to support it. The other thing, and it was on the algorithm list but wasn't really mentioned, is the Medicines for Children policy, which is really important. I don't know if there's any paediatric clinicians in the audience, but it does allow access without NICE guidance to medicines for children, depending on if there's a license that's been updated since NICE looked at the drugs, or if there's a published dose, perhaps in BNF for children, or finally, if the child is post-pubescent. And again, there was toing and froing about should it be 12, should it be 40 kilos. Post-pubescent was the one that we stuck to, because that basically says the child is adult from a pharmacokinetic, pharmacological perspective, and therefore should be handling the drug in exactly the same way as an 18-year-old. And what frustrated me about all of this was, 17-year-olds were being denied access to medicines because they were 17. There was one kid who had colitis, who couldn't get out of bed because of colitis, couldn't get to school. But he was denied through individual funding requests because he was part of a cohort, which is, to me, ridiculous. So if you're not aware of it, we've got this commissioning medicines for children. And just back to the algorithm, and I thought we had added ocrelizumab, but I have checked with colleagues and we haven't. But the good news is it's not going to take 2.5 years to add ocrelizumab. We can just add things now. It's been through the process, so anything new will just get added. And one of the things I'll do when I get back to the ranch is get that sorted. So, I was going to talk about Bluteq, wasn't I? Why do we use Bluteq? What is it? Those who have used it will know what it is, but basically it's a web-based system to notify us that you're going to put somebody on a medicine, okay? And in fact, it was used by PCTs prior to NHS England. It was certainly in London, it was in the south, partly in the south, and in fact, the south tried to introduce Bluteq before we were even looking at it and caused a bit of ruction, I know. But I think we're pretty much there now. And certainly Rachel will know that we look at these Bluteq forms to the nth degree to try and make them as simple as possible and logical and meaningful. But the reasons that we tend to use Bluteq, and now all cancer drugs that go through NICE have a Bluteq form, all hepatitis C drugs have a Bluteq form, and as you will know, all MS drugs will have a Bluteq form, and that's not going to change anytime soon. But from the perspective of why we use or even consider Bluteq in the first place, it might be because it's going to be used in a subset of the population compared to its license, i.e. NICE says it'll only be used in these circumstances. The policy identifies a specific threshold when the intervention can be used. The policy identifies specific stop-in rules for the intervention. The policy relates to an intervention disease where appropriate approval is already required for other interventions. So we're trying to find out where the drug's being used in several indications. Or it's only allowed in specific trusts. So if a trust doesn't have Bluteq uploaded into their system for that particular drug, they can't use it because they won't get paid for it. So those are the reasons we have Bluteq in the first place. And of course, we can try and use Bluteq to audit what's going on. We can have a look and see what's happening. So what information can we extract? So this is kind of uptake, and I kind of almost ripped up my slides when one of your colleagues said, well, we don't want an annual look at slides showing what Bluteq tells us. But anyway, so this is up to the end of 2018, so our financial year. And there's a couple of things you could pick out, like in London, or is it the northwest, sorry, that sort of browny, horrible colour is glatrum acetate. So Manchester, I think, particularly use a lot of glatrum acetate, so thank you very much, because it's relatively cheap. But in Yorkshire and Humber, just conversely, and I don't know why, they don't use much alemtuzumab. And there may be a reason for that, or it might just be they haven't got round to using it, so that's that little grey thing at the top there. So we can have a look at the sort of ratio of uptake in use. And some of these you can see are much of a muchness, but there are differences, and there are things that we could go, oh, I wonder why that's the case. We can look at patient numbers, obviously. We can see how many patients are on the different treatments. So this is individual patients being registered on Bluteq, and where they're being looked at. And obviously we can drill down further than this, but I wasn't going to put up individual trusts. And obviously there's a lot of activity in London, there's a lot of activity in Yorkshire and Humber. But again, we can have a look and see whether there's variation, why there is variation, and if there's something we need to do about it. And we can do some funky things as well. So we can look at demographics. So this is sort of where patients live by their GP, CCG, and where they're going to. So we can look at hotspots. We can look at all the drugs and where they're prescribed as these sort of tower blocks. And this is the sort of thing maybe when we talk about publishing, maybe this is the sort of thing we'd want to publish, because it gives a sort of a general overview of what's going on. We can look at individual drugs and where they're being used. So over there in the southwest, and down here in the southeast, and a little bit around Cambridge, I believe. So, so we can have a look at that as well. Now, EDSS. So when we start to look at Bluteq, Bluteq is really sort of a prior approval system. Now, back in the day, and certainly with some CCGs even now, you'll have to fill in an IFR form for certain things. And that's really just a prior approval system. What Bluteq does is give you an instant reply. You don't have to wait for a letter or an email back from a commissioner to say, oh yeah, you can get on with that. You'll get an immediate reply from Bluteq to say, yep, that's fine, you've ticked all the right boxes, so get on with it. And we added EDSS at the beginning as a non-mandated field, so you didn't have to fill it in if you didn't want to. Just because, you know, we were thinking about, well, actually, could we use Bluteq for something else, like start looking at outcomes, because, you know, expensive drugs, yes, nice to think they're cost effective, but actually, do they actually do what they're supposed to do in the real world setting? So we added EDSS, and then when we started looking at Bluteq forms again and updating them, because we'd had a bit of feedback about, you know, some of these questions didn't really make any sense. And we were talking to the patient groups, and we were talking to the ABN, and they said, why don't we make this a mandated field? So you can blame your colleagues and the patient groups for why you have to fill in the EDSS, because we were asked to do that. But equally, I think over time, and I don't think that time is here yet, and you'll see in a minute why I think that, it could be a really powerful tool. Now, EDSS might not be the right thing to measure, but I think we should be measuring something, and I'm more than willing to listen to all of you and decide what is the thing. Employment isn't it, I have to say, because obviously people just aren't employed sometimes because they can't get a job. So it's not going to really work like that. But if there's something else, that's absolutely fine. So we mandated the EDSS around 2017, might have been 2016. We also asked for annual updates, which I think is important because it tells us that the patient is still on treatment, and obviously you have to put in the EDSS score again, so it gives a track of a patient over time and their disease. You have to fill in the new form if it's a new drug. And we've now got over 25,000 scores recorded. Are those 25,000 scores real and legitimate? Not so sure, and you'll see why in a minute. But we've got 25,000 scores. And interestingly, we've got 165 scores above 7. Now, again, I don't know if it's just because clinicians or whoever think, oh, well, you know, this is ridiculous. I'm just going to put 9 and see what happens. It's not really useful if they're doing that. It would be nice if you actually put in the actual EDSS score. But there is 165. There's a few that are 9s, as it happens. But more importantly, we've got 619 scores with three EDSS scores now. We've got 43 with 4. We've got 8 with 5. We've actually got 1 with 6 scores. And it's too early at this point in time, I think, to start looking at this and publishing it. And it's not research. So you don't have to be exact about the EDSS score, but, you know, accurate, but not exact. And we're not going to publish anything anytime soon. Somebody else might. But it is what it is. So, first patient. Initial is supposed to mean it's their initial form. But this one looks a bit strange because apparently they were started on beta interferon on the 5th of the 6th, and then they were started on beta interferon on the 14th of the 6th. The dimethyl fumarate maybe is a bit better, changed on the 14th of the 8th, but then started again on the 10th and 9th, and started again on the 24th and 9th. So I don't know what's going on there. Maybe somebody just thinks they have to fill in the Bluteq form every time the patient turns up at the clinic, which you don't. You just need to do it annually. But you've got the EDSS scores recorded there, and that looks like things are going okay. According to, I didn't put the whole data on there, according to the data, the first 2 were stopping beta interferon, and it may well have been that they'd been changed to a different version, and I didn't put that up either. Second patient, this one looks a bit better. So you've got dimethyl fumarate started, and then switched to interferon beta, which is sort of allowed, I suppose, as long as they're having an adverse event. And then switched to glatiramer acetate, again, which is sort of allowed if they're having a reaction to interferon and they haven't progressed, obviously. The patient hasn't progressed. And then switched to cladribine. But again, 2 recordings of the cladribine, and I'm not sure if that's, again, because patients come in for second doses or what, I don't know. But it's sort of given us a pattern of patient progression there. And finally, and again, not quite sure what's going on initially, but there is a switch to alemtuzumab. I'm sort of thinking certainly the third alemtuzumab is their second cycle, which is great that it's been recorded. And also, it looks like the patient's doing better on alemtuzumab when they got switched, which is, you know, perfect. So, to me, it's early days with the EDSS score. But I do think, if it's recorded appropriately, we can, over time, look at how these medicines are working. We can look at which drugs patients are being started on, switched to, left on, how long they're on it for, how quickly the EDSS score progresses, and we can utilize that to feed back into things like NICE when they're reviewing their technology appraisals. So, future possibilities with Bluteq, for me, obviously, I want to continue to collect this data. I think it will be useful at some point in the future. I think we could publish it, but I think particularly individual trusts can get the Bluteq data out. I will look into how complicated it is. You can ask Bluteq actually for standard reports, so they will do bespoke reports for you if you ask them. So you can just download that bespoke report. But you could, you know, show patients your particular trust and what you're prescribing and how patients are getting on with individual drugs. We can share the information. We have shared information with GERFT and a couple of research teams, again, to look at that sort of EDSS score, and that will get better as we move on. We do try to improve the BT forms, the Bluteq forms, and again, any feedback is gratefully received. We're not going to update them anytime soon because it takes about a year once we do update them. But anyway, we will, if you wish them to, be updated. We have added, again, at a request of the patient groups, that those non-mandated fields about when a patient first felt they had symptoms and when they were actually diagnosed. And again, that would be useful to fill in if you've got the time to do that, but it's not required. And then the other thing, which I think we did this for Hep C, or we've started doing it for Hep C, because we know there's a lot of patients out there who've got Hep C who aren't in the treatment centres at the moment. But we could, I suppose, use Bluteq to register a patient with MS, not necessarily on treatment, but just to say that that patient has MS. And we could start doing that if you thought that was a good idea. Thank you very much.
Shamin?
This is why I put my helmet on, is it?
So this is actually not a question to you as much as to everybody over here. Could I ask one question? This is a show of hands over here. How many people feel that having to do a proper EDSS rating will take up enough time from your clinical practice to, in one way or the other, adversely affect patient care in any way? The people over here, anybody who feels that the time constraints to actually do a proper EDSS will impact on your ability to actually care for your patients, to give the time they need. Just to get a hands up over here, how many? And how many over here just sort of feel it wouldn't at all? Well, wouldn't significantly affect?
The trouble is, it depends on whether you're given the time.
That's the point. That's the point. But under our current abilities to provide a service, what I just wanted to show is that as it stands at the moment, most people, at least on the show of hands, would in some ways have greater difficulty with patient care. I mean, it's a simple point. Nobody's arguing here about the importance of EDSS, the need for EDSS, the need for outcome monitoring. The issue is whether right at this moment we should have a parameter there which is mandatory, which therefore forces us to change the way we practice our medicine, our neurology, and which, just on the show of hands, a majority seems to suggest that there would be a negative impact on care. That's simply the question.
Maybe it's because I was standing up here, but it didn't look like a majority to me, but hey.
I think not all this audience are neurologists, so a lot of people didn't put up their hands, or people who are not neurologists. So I think in terms of the neurology community, most people put up their hands, I would imagine.
I agree that we need to monitor the patient's efficacy of the treatment and everything, but doesn't mean that we need to put the EDSS. If we assess the patient neurologically, we put details in the notes and we say the distance walking, what they do, and we can compare later. But I think that the number what we put on the Bluteq, it would be the best if we just put below or 0 or below or equal 6.5. In that case, patient is still eligible for medication. But we write clearly the neurological examination.
David?
The easy way around this is the right tool. I don't have time to do it. You just need to estimate it. Because the worry that I have is that you're using this for research purposes, or it's being given out for us, and it will give you information in the long term. So the EDSS was not designed to show a difference, as you know, over a short period of time, but it will give you an idea over long. So estimate it. If we just put that word in, a lot of us, I think, would feel a lot more comfortable, because at the moment we're lying on the forms. We're putting an EDSS, we're making it up.
Just a comment. I'm definitely a part of EDSS bashing brigade, but EDSS is actually accurate up to 3.5. The difficulty is from 4.5 to 6, and that's the distance walk. So 300, 200, 100 meters, and this is something which we can't do in clinic, no matter what. So up to 3.5, you examine your patient reasonably, you will be able to estimate reasonably well up to 3.5. And obviously 6, 6.5, and 7, and so on, it's quite easy. So there is a gap. So, yeah, that'll be my comment.
Yeah, so we've created an EDSS calculator which validates relatively well. We're going to improve it, so people are welcome to use the calculator. Question at the back.
EDSS is only one part of decision making. When I have a patient in the front of me, I look at the patient, their employment status, how much they have to lose, their cognition, their MRI scan. Why are we putting so much emphasis on EDSS? Yes, it is important to collect the data, how the patients are doing, so we can prove that these drugs are working. But I think it's an obsolete measure nowadays.
I said earlier, I'm from Glasgow. Unfortunately, we're not mandated to do the ESS score, but we are mindful of the fact that we do have to monitor our patients. So we use our outpatient nurses to monitor our patients. All patients on an annual basis who are on DMTs get a 25-foot time walk. They get a 9-hole peg test. They get visual acuity measured. They get cognitive assessment, and they get some quality of life measures as well. We've also introduced U-Motif to patients. So this is an app which patients can take away with them and monitor their symptoms over a year and bring back to us at the end of that year.
So that's very useful. So just to say about EDSS 7, sometimes we get people who come in with an acute relapse and they're off their legs, and we start therapies in the anticipation that they're going to recover function. And so it would be unfair to deny a person who has got transverse myelitis with an EDSS of 7, 7.5 or 8, to delay starting a treatment, because we anticipate those people recover. So those 7s may be those kinds of patients, I'm not sure. Yeah.
I'm still waiting for a question. These all seem to be statements. Shall I just respond into the general terms of things? So, as I said earlier, we were asked to make the EDSS a mandated score by your colleagues and by the patient groups. And if EDS isn't the right system, that's fine. We did consider doing a less than 7 or 6.5, but having spoken to the steering group for the sort of Bluteq and the algorithms, we thought we'd actually do a score. But as I say, I'm more than happy to think about alternatives. We don't expect the consultant neurologist to do the EDSS score. In a lot of clinics, it's not the consultant who's actually doing the scoring. It's a nurse. It's not even a nurse in certain circumstances. It's somebody who's trained to be able to do the EDSS score. So, you know, I'm here to listen. I've got colleagues in the room who work with me on these things. We will listen to what you're saying. It's a shame neither Adrian or Alistair is here, but nevertheless. On the 7s, I absolutely agree, and we don't say, if a patient hits 7, they've got to be off it. It should be, a 7 consistently over some time. But once they have hit that 7 for a period of time, then we think they should come off. And the reason for that, largely, is because NICE considered the cost effectiveness around the fact that the patient was ambulatory. They didn't take into account once a patient is in a wheelchair, because that changes the cost effectiveness. And some of these drugs would not be even available if NICE had started looking at scores above 7, for instance.
Last question.
Yeah, so I think that the debate around EDSS is very useful, and I think one of the worries I have is that the business of the DMT clinic should be, at least in large part, are we controlling disease activity or not? And if not, what drug do we need to be using? And then we have these Bluteq forms that has the drug on it, and then it has an EDSS, which is not a disease activity measure. It's a long-range outcome measure, and it's a slightly crude one at that.
Yeah.
And I think actually, if we're thinking about what drug we're using when, and if there's disease activity, then we want a disease activity measure, and I think it has to be something else, like neurofilament levels, for example, that is showing us disease activity, not a long-range, long-term outcome. And the benefit of just changing to that is that whilst it looks like a big leap of faith, it doesn't have to be done in the clinic. It doesn't have to take up consultant in-clinic time. And I think as long as we're willing to write in these targets into algorithms then at least we're doing something practical and measuring what's going on now.
Okay. A very good point about activity. We'll have the feedback to Malcolm and the NHS England about the kind of ideas we want. But at the end of the day, we also got to make these things, these suggestions, pragmatic and practical. There's no point in making the measurement so complicated that we can't do it. Maria? There's a microphone there.
I would like to bring forward another theme from your presentation. Just quick, in Essex, I was able to prescribe natalizumab, and in East Sussex, I'm not. So my question to you is there a kind of unifying concept of what it is an MS prescribing center? And this kind of qualification exists or not?
Well, we put something in the algorithm about what a team should look like. And of course, for the newer drugs, particularly the monoclonal antibodies, but cladribine's in there as well, we've said the decision has to be done through an MDT. Who can prescribe is down to the local commissioner. So the local hub, and it might be a different hub, but those two trusts might sit in different hubs, I don't know, but not knowing the south very well, coming from the north. But it may be that that particular hub doesn't feel that that particular hospital should be having access to MS drugs. Having said that, if you're a visiting consultant to that trust and they don't know that, then perhaps that trust needs to advise them of the fact. Because it is bonkers that you can prescribe in one trust, but not in another. So I think you need to go back, talk to the service manager or whoever, and then they need to talk to the local commissioner to get that sorted. If it doesn't get sorted, drop me a line.
Okay.